Hello, everyone, and welcome to this week's episode on Fit as a Fiddle. Our guest today is Leia Mitchell. She is a women's sexual health PA in New York, and she works at the Centers for Vaginal Disorders. She has also recently published an article called Identifying a Correlation Between Hypermobile Ehlers-Danlos Syndrome and Genitopelvic Pain in Cisgender Women. And she has also won the Irwin Goldstein Best Abstract Award at the International Society for the Study of Women's Sexual Health, or ISWISH. Leia is amazing. She has, wonderful, wonderful grasp on sexual medicine and women's health and pelvic pain, and works very, very, very closely with hundreds and thousands of people in and around the greater New York area. People come from all over to get help because this is a very, very specialized field. And she's like one of the only PAs around this area who's so specialized, not only in clinical care, but also in research and publications and putting knowledge out there, because I take from this knowledge and use it in my practice. So we are also ever grateful for people who do the hard work and getting research that's so vital in our clinical care out. So thank you so much for the work that you do, and thank you for being here today.
Of course. Thank you so much for having me, Sneha. It's great to be here.
Yeah. So I want you to just first go ahead and tell us about what made you come into this particular field in medicine in the first place, and what kind of brought you into the subset of also within Ehlers-Danlos as well.
Of course. So I grew up with a family woman. My mom is one of four daughters. So I was always grew up around women. And then I knew just kind of early on that I wanted to be in the medical field and I wanted to provide care for people. And that background of just being around women kind of pushed me into this direction of wanting to work with women and improve women's lives. And then after I went to Georgetown University to get my master's, I wound up at Andrew Goldstein's doorstep, where I accepted a position as his clinical research coordinator. And I was able to learn from him for about, I think it was about 4.5 years that I was with him. And I was working side by side with him and really learning the intricacy of women's sexual health and how all these women have these issues and nobody knows how to diagnose them. So that really gave me that farther push to go to PA school. And then right after PA school, I went right back into this field because I knew that we needed more women supporting women and making sure that they get the care that they deserve.
I love that. Okay, so what about Ehlers-Danlos interests you?
Yes. So that's a little bit of a loaded question, but there's multiple layers as to why I went into doing this deep dive into Ehlers-Danlos. One was we're just seeing a correlation between women coming in and just being hypermobile or having chronic pains throughout their body, not just genitopelvic pain. So that kind of drove me to do a deeper dive. But also, I personally found out that I have Ehlers-Danlos syndrome. I'm on the more mild side, but my journey kind of started off with having a bunch of hip pain, and then that led into my own genitopelvic pain, and then realizing that I had labral tears in my hips that I needed to correct. And the more I learned about myself, the more I learned about my patients. And so that drove me to really understand Ehlers-Danlos syndrome from kind of all different aspects. But being a patient, I feel like really helps you understand what these women are going through and what people who deal with EDS go through. So the more I asked questions with our patients, the more I realized that there is such a huge connection between hypermobility and pelvic pain.
Yeah. This is actually independent of, just our conversations and getting to know you more.
Mm-hmm.
I had realized with my patients who had any level of EDS, because I've seen a little bit of a spectrum, that being a pelvic floor PT, even though I'm not necessarily there because their primary complaint was a pelvic floor disorder, I found when I've spoken to them, they've been like, oh yeah, and these are issues too. I didn't even know people could help us with these. pelvic health related kind of problems. And I was like, yeah, this is what pelvic floor PTs do. And it's, I think it kind of gets lost because as it is, pelvic health, right, and it's in and of itself is underdiagnosed, hard to talk about, under-researched, underfunded, all of the unders. And then EDS is just such a vast, complex genetic disorder that presents in so many various ways. And so when you combine those two together, it's like even more niched into this like tiny subset of like care that's so specialized, that needs so much work. And so I love that when you and I first were starting to talk, that we were actually only connecting on the pelvic health aspect, and we realized how much we had in common with our EDS worlds as well, and how these are so related, and how it's important to have these conversations and bring more light to these patient populations and the things that are going on with them. So having said that, I would love for you to start talking to us about your article, your research, and the work that you put out that you had wonderfully just won your award for. So yeah, I'll let you just get started, and however you want to talk about it, maybe kind of like what was like the initial methodology, and what were some of the challenges initially, and what did you finally come across at the end?
Yeah, of course. So we what we did is we analyzed women over about a 7.5 month time period, and we looked at all the women that presented to us as new patients complaining of genitopelvic pain. So we weeded out all those patients that came in with any dermatologic complaints, because a part of women's sexual health is also dealing with of course, the vulvar derm issues. So we weeded out all the vulvar derm patients, and any new patient that came in from the past 7.5 months were a part of our study. And what we did is we had every single patient answer what is called the 5-point hypermobility questionnaire. Now, that questionnaire has a really good specificity, and I'm drawing a blank on the names, but specificity and sensitivity rate. So it's really good at telling you who is hypermobile and who's not. So if someone answers yes to 2 or more of those 5 questions, they have a really high chance of having hypermobility. So we took those patients that answered yes to 2 or more, and it was about 200, let me get the exact number. It was 246, I believe. 200, roughly around 246 new women that we screened. And of those women, about 1/3 tested positive for hypermobility. And of those 1/3, 98% had pain at the vestibule, and about 95% of those patients had pelvic floor dysfunction. So it was just really eye-opening to the correlation. I mean, every single person that screened positive for hypermobility had genitopelvic pain. And then that also doesn't even go into play the patients that had pudendal neuralgia were also on that list, and patients that had recurrent yeast infections were on that list, because we found that when I did my deep dive into EDS, there is a really high correlation between patients who have EDS and their increased risk of also having something called mast cell activation syndrome, which mast cell activation syndrome is a whole nother processes on its own. But a lot of women who have EDS also have this syndrome where their mast cells, which are one of the cells that is activated during inflammation, they're just overproducing them. And anytime you have inflammation, there's just a lot of mast cells, more than the normal in the area. So what that causes is release of histamines and release of nerve growth factors. And I know I'm going down a little bit of a tangent here, but all of that plays into genitopelvic pain diagnoses, having hypermobility, having mast cell activation syndrome. And of course, as you know, the myofascial sequelae of having hypermobility is huge, and it can affect not only your pelvic floor, but all of your joints. So we're saying not only are these women coming in with pelvic pain, but they're also telling us, oh, I have a history of chronic neck pain, hip pain, back pain, and it's been going on for 10 plus years. And I mean, at this point, I just deal with it. But my genitopelvic pain, I can't just deal with it because it's affecting my life on a whole different level. So this research has really opened our eyes to the fact that hypermobility is crucial in women's sexual health. And we need to continue to do deeper dives into how EDS affects our pelvic health and how we can getting to the root cause or root problem of their pelvic pain is the most important part, and that's how we operate. So now that we're able to diagnose them, okay, your hypermobility is the problem, then we can work on their hypermobility rather than just treating their symptoms, so we can get to the root problem and actually find them not necessarily a cure, but find them lifelong ways of avoiding the pain and helping them out. So that's a little bit of a long story, and I know I could probably talk your ear off about the research, but all in all, we know that there's a correlation, and there's more research that I'm working on as we speak to learn more about how EDS is affecting genitopelvic pain.
I love all of that. I'm so interested to hear your take based on what the research is right now and what it's been showing. How do you feel like people can use this knowledge, especially as physical therapists, almost immediately when we're looking into patients who are coming in with pelvic pain or of any kind and genitopelvic pain of any kind? What do you think we should be doing?
I think screening, just doing that simple 5-point questionnaire, which it talks about, like, have you ever considered yourself double jointed? Can you or have you ever been able to touch your palms to the floor? There's questions about, as a child, could you contort your body into weird shapes and you would amuse your friends doing that? There's a few other ones I'm missing on, but just simply asking those questions or just screening them for hypermobility. So there's this score called a Baton score, where you look at their thumbs. Can their thumbs bend back and touch their forearm? Can you bring your pinky back up to 90 degrees? Is there hyperextension of their elbows, of their knees, and can they touch their palms to the floor? And that can take you about 3 minutes to test all of those things, and the score is out of a 9, and if they score 5 or higher, then they have hypermobility.
Yeah, that's wonderful. Yeah, Baton score is definitely something that PTs are very, very, very familiar with. Or at least should be very familiar with. And I think that the hypermobility scale that you mentioned right now is like a great one to just hand out when we're doing intake forms. Because we have to give objective measures to our patients anyways. Like I often use things like the back index or the neck index or the oswestry or different kinds of things for my orthopedics or the LEFS or whatever, different kinds of scales for orthopedic conditions. And especially with our pelvic, we have multiple pelvic floor, different kinds of pelvic floor objective measures too, depending on what kind of complaint people are coming in, whether it's a prolapse kind of symptoms or incontinence kind of symptoms. When people are coming in with pelvic pain, we have certain questionnaires, but this is a great one to add along. And then when we're doing our objective screen, doing a Baton score, it takes probably not even 3 minutes, probably like a minute or less, honestly. If we just have it, we can just observe it when we're watching them doing other parts of our objective screening. So those are great. And then I think that when you do get your results back, and if you do see that there is a correlation, if your patient is coming in and they're scoring like 2 or more, right, on the hypermobility scale and scoring 5 or more on the Baton score, on the Baton scale, there is so much information from there as a physical therapist that we can now include in our plan of care, right? So like the first few things that are coming in my head is, like, classically, when we're coming in with a patient who has pelvic floor dysfunction, that's pelvic pain, we want to do, and this is a very, very blanket statement, every patient is different, so I just want to say that. But typically, we first want to understand, how can we desensitize their body? How can we allow for there to be good mobility of their pelvic floor and surrounding areas? And how can we, incorporate ways that patient can understand their pelvis and the adjunct structures to that area really well, right? Developing awareness. And now with this addition of understanding that this person might also have hypermobility, not that these scales diagnose them to have EDS, because the only way to do that is getting a genetic test, of course. But just knowing that they might be at a higher risk of having EDS, that focus can now help us understand and guide our treatment in terms of exercise and manual therapy, right? Because one of the most important things, like especially as somebody who's treated quite a bit of EDS, we don't want to do a whole bunch of huge manual manipulations and mobilizations to that patient. That is something that is typically contraindicated or typically not indicated for a person who's presenting with hypermobility. You don't want to make their joints looser, right? You want to create more harmony and balance in those areas. So there is, of course, some level of manual therapy in certain cases that's super helpful. But we don't want to do crazy mobilizations and, big kind of manipulations to the joints. So that's like the first thing that comes to my head. And then the second thing is stability work, which is so important. I'm sure you know this because you have experienced this in your life, but when you are able to keep your body stronger, you have typically less symptoms, right? I guess I want you to speak to that as somebody who studies this and somebody who has EDS as well. I'd love for you to touch on how movement and exercise plays in your life.
Yeah, it's a huge role. I mean, so first things first is I used to be this avid yoga. I was a yogi. I did it almost every day. And then once I realized, I was like, oh, I'm like strangely good at yoga for some unknown reason. I just started and then I was like, oh, I'm pretty good at this. This doesn't make sense. And then I realized it's because I was hypermobile. I could go into these positions deeper and then I was getting more pain. And I didn't realize that because I thought yoga was this great exercise for me and it was strengthening, but actually I was going so deep into these poses that it was actually injuring my joints more and causing me more pain. And I didn't understand that correlation until I realized that, oh, I am hypermobile. And then I changed my workout routine to be more focused on strengthening my joints and doing weight training. And that was a huge game changer. The more weight training and joint strengthening that I do, the less pain I'm in. And I notice if I fall off the wagon of working out for let's say a week or even sometimes 3 days, even I can feel the pain creeping in. I'm like, oh, okay, I got to get back on it. And it keeps you very regimented, and it's very important for pain, like the chronic pain that you have as EDS patients. And I did want to note one thing, just treating patients with EDS and also diagnosing them with EDS. So the hypermobility EDS, there is no genetics blood marker for the hypermobility part, but the 12 other EDS ones, there are. So seeing an EDS specialist is very, very important to make sure you wean out those other ones. But once I diagnose these patients with EDS, they're like, oh my gosh, this makes so much sense. All these symptoms that I was having, I thought they were just all different. And I thought that's just the way I was. Like, I thought that I was just someone that always got dizzy when I stood up, or I just was always tired and suffered from chronic fatigue. And there's all these crazy symptoms with the hypermobile EDS that patients just think is normal, or they're seeking help from multiple different providers. So they have 5 different providers and no one's diagnosing them because they're not putting together the pieces. And EDS is this zebra syndrome that nobody's diagnosing and no one's screening for. And what we really need to do, and I don't know how we would be able to do this, I haven't figured it out yet, but is we need our pediatricians to screen it, because when we catch them early and we catch the hypermobility as children, then we can kind of guide the kids into preventing injuries, making sure they're running properly so that they don't cause injuries or roll their joints or cause tears in their joints. And starting them young will help prevent chronic pain in the future. So that's kind of the goal that we need for patients with EDS is early screening, but it is just hugely important to keep your joints stable, because if you don't have stable joints, then every EDS patient is at increased risk of injuring those joints. And that's just how it is, because our collagen's just not as strong as it should be. So yeah, it's very, very important to stay active, and early diagnosis is always key, but it's interesting. And I could obviously talk for hours about it because of my personal experience and our patients, but it's just really important that we keep doing research.
Yes, I love it. I think that the most important things that you said here was the screening early piece, because I think that like if we could just do that, we just prevent so much, honestly, just jumping from doctor to doctor. I've so many patients who've had EDS who just didn't know for so long, like you've mentioned before. And I think people should just have more awareness about it, especially from a young age, and be able to like select sports and exercises and activities appropriately. Not saying that they shouldn't do certain things at all, but if there are certain diagnoses of certain types of EDS where maybe playing football is not the best idea, and getting so much impact on your body is probably not the best idea. Not saying that nobody with EDS can ever play football. I'm just saying that there are certain it's a vast spectrum, right? So knowing what you have is helpful for treatment and can help your practitioners advise you appropriately. And I think, just being a physical therapist, we play such a huge role in strength and stability and movement and making sure people are moving well. And many physical therapists don't really know a whole ton about EDS. Maybe they know a little bit about hypermobility in general, but not about the EDS implications, about the fatigue and the mast cell and the POTS and like so many other things that are involved with somebody who actually has one type of EDS. So yeah, so much to talk about, such interesting research. Thank you for doing research, honestly.
Yeah, of course. Of course.
It's so hard to do, and I'm so grateful for people who have the strength and stamina to keep up with articles and publications and all that stuff. So
it's the only way we can get our patients better, because there's not enough data and not enough research on women, especially in the sexual health realm, that we just need to keep pushing, learn more and more as much as we can.
Absolutely. Amazing. Okay, so we definitely have to do another podcast, and then we got to delve deeper into like either just like the pelvic health aspect of things or the EDS, because today we talked about a lot of both of it, and I'm sure that the research is going to evolve and we're going to find some really cool things as time goes by. So we're excited to have you back on the show at some point in the future.
I can't wait. I can't wait.